So we diagnosed him with community-acquired pneumonia. And in terms of our 6-hour bundle element, we did actually hit all of our goals. He had his lactate screening. We did that Q6 hours times 24 hours, then Q8 times 2, and it did normalize quite nicely. His PCT was repeated the next morning, and it went down to 2.5. His blood cultures were drawn before antibiotics. He got his broad-spectrum antibiotics based off our antibiogram, so he got Benco and meropenem, and we do that by location. So whether it's neuro, skin and soft tissues, lung, bowel, that type of thing, we do guide our antibiotics based off location of possible infection. And then in early goal-directed therapy, all of our goals were met. He got 4 liters of saline in the ED. He did start off with some dopamine, although we're using more Levofed these days. His CVP was greater than 8 in 6 hours. His CVO2 was greater than 65. His mean arterial pressure was over 65, and his crit was up, and source control was not required. In terms of the 24-hour bundle element, we did meet his goals. He was on a 6-hour AccuCheck protocol, and we did achieve glycemic control. He was not intubated. Zygros administration began within 8 hours because he did have greater than 2 organ dysfunctions, and his pressors were required post-fluid resuscitation. We ran at 96 hours with no side effects noted, and he did get steroid administration because he was pressor dependent. And we don't do our ACTH DIM test here, by the way. The PCT trended QAM, and it reduced to baseline within 2 days, which to us indicated the efficacy of our empiric antibiotic choices, and he did not have a bump up, which to me would show a secondary infectious complication. So at date of discharge, he was ambulating well with mild weakness. His quality of life was maintained. He went back to being a resident. He was discharged with Levaquin and a regular diet, activities tolerated. He followed up in 3 weeks and did get a chest x-ray, P and lateral. So I think the bottom line is, and I love this, in healthcare, work processes are seldom specified. Our systems are really simple, and we seldom use a scientific method for improving our processes. My job here at Mission and at my previous facility was critical care performance improvement, and it's only through a very defined, algorithmed approach can you turn a good program into a great program. So here's my little quality management hat I'm putting on now. Certainly, if you look at the bottom, we must have an organizational consensus that severe sepsis must be managed early and aggressively. We have to develop early triggers and tools. We have to implement a very excellent sepsis bundle initiative, and you have to measure success. I am a data fanatic. I collect over 30 data elements specific to sepsis. I love collecting data for sepsis. So let's talk about the deliverables for a comprehensive surviving sepsis campaign initiative. Now in the ED, we have to set up SIRS criteria for triaging sepsis. You have to find a way to initiate the early goal-directed therapy, and you have to somehow improve throughput, because we know early goal-directed therapy can be difficult for the ED. We have to not only do education for the nurses, but for the physicians, and we do CME here at both my hospitals, as well as yearly mandatory 1.5-hour education on sepsis, mandatory, just like ACLS and BLS, because it is our #1 mortality risk at our hospital. In terms of labs, ensure that your lactate, we have point-of-care testing in the ED as well as regular lactate drawn from the lab on the floors. And procalcitonin, we have currently at our mothership hospital, and we do have a smaller hospital, Laguna, that they actually have to drive up the procalcitonins to this hospital. It's about 20 minutes away. But our turnaround time is only 40 minutes, just like a basic metabolic panel. It only runs in 20 minutes, but the time it takes to run and get down there and be resulted. And it's imperative that you really encourage the manual differentials on those CBCs to look at bandemia. So that is kind of our sepsis panel that we use. We have an EMR high alert report that the rapid response nurse actually looks at, and I'll show you an example of that in a moment, and a very good, strong policy, procedure, and guideline for the entire initiative. the ED or ECU and critical care order sets, as well as a med-surg order set, and data collection, monitoring, analysis, looking at local, regional data comparisons, and then looking at your 6 and 24-hour bundle effectiveness testing. We do have the rapid response team that's fully integrated. It's a proactive initiative. They actually seek out infected patients and those that have a positive sepsis screen, and then you have to look at their empiric antibiotics recommendations. Our rapid response nurses actually go to all positive sepsis screens. Our bedside nurses are expected through the EMR to screen on every floor, every patient, every shift for sepsis. And if they have a positive screen, the rapid response nurse goes to the bedside and will order a lactate, a PCT, and a manual diff when they go. They also do go to the ERs for all code sepsis. We also have this information track and trigger system. We pull what we call high alert or high risk physiologic variables. It's not only for sepsis, but it's for other indicators as well. And so it looks at BP min, BP max, SAOC min, pulse max, etc. Anyone that's on electronic charting can do this. So our RRT nurses actually run this report, look at how many red flags, and then from there they can proactively round on the patients that they think are high risk for deterioration. At Mission, these are just some of my data, but I have many more data. Our median ICU length of stay has been reduced by 1.5 days. Our median hospital length of stay was reduced by an additional day. Our mortality reduction was statistically significant from 30 to 16%. Our acute renal failure rate requiring dialysis has been reduced from 18 to 12%. That is not statistically significant, but you know what? For each patient, it matters. And for acute respiratory failure, our rate has been statistically reduced from 58% to 35%. So the earlier you recognize them, the more aggressively you treat them, the less they get intubated. And my N numbers on that, I have 57 in my baseline data, and I have 275 in my post-implementation data. And while I say 57, I did a full year's data that showed that 30% mortality rate that had 365 patients initially. But in terms of looking at the renal failure and respiratory failure and all that, I did a drill down with only a convenient sample of 57. This was Manny Rivers' post-early goal-directed therapy analysis that he did. And Hoag Hospital is on here. That's included in these data. That's where I worked previously. And all of these hospitals to the right provided Dr. Rivers with his data. He aggregated them, and he showed that basically the summary of centers that he was involved in with early implementation showed that statistically significant improvement. And the take-home message here is you only have to do this initiative 5 times to have one unexpected positive outcome. So I think that that's so exciting. It's certainly worth our time and energy, and our patients deserve us being able to do this. Here are my basic core reference articles, and that's really it.
Thank you so much. On behalf of bioMérieux and all the attendees today, thank you for that excellent presentation.